So I am here with Dr. Panda, who works over at El Paso Children's as a neonatologist. Welcome, Dr. Panda.
Thank you.
And then I'm also here with Armin Valdez, who everybody knows. He's one of our pediatricians, who's our new emergency medicine resident as well. So today, Dr. Panda has joined us to go over the AHA guidelines for neonatal resuscitation. He is a neonatologist over at El Paso Children's, as I said. Dr. Panda, do you mind actually telling us a little bit about your background?
Sure. So after completing a pediatric residency, I'm an international medical graduate, did my med school in India, then did my residency here in Corpus Christi, Texas, then did a 3-year fellowship in neonatology. It's neonatal perinatal medicine, to be more descriptive, in New York Medical College, New York City. Then basically came back to Texas to join here. This is my first faculty appointment, and I've been here for 3+ years now. And yeah, NICU is my world.
So these AHA guidelines, they're not for you at all. I'm sure you do this every day. You're very comfortable with it. But for a lot of us, especially we're going to be covering small emergency departments throughout the country. So from time to time, I'd imagine there's going to be somebody that's going to come in and they're going to give birth, and we're not going to have a lot of backup. So these guidelines are very, very simple. The box is very easy to read. I can imagine if I was at bedside, I can go through these. But obviously, there's like an art and a science to this that you know much better. So what I was hoping to do is just kind of go through step by step and just get your expertise on these sort of things. So really appreciate it. We could just get started on it.
Okay.
So the very first thing it says is antenatal counseling, and then a team briefing and an equipment check. So you can imagine if we are in the emergency department, generally some people will be coming by ambulance or some people will come in through the front. We'll have a few minutes to kind of get our stuff ready. If we have that time, how should we prepare? What should we gather, do you think?
Sure. So to begin with, I'm going to try to talk in terms of we are in emergency room where you don't have a neonatologist on call and may or may not a pediatrician also. And it will be the emergency guy who is going to handle it till we have some other support or help coming their way. So the first thing to think of as the ambulance is rolling in, or if you get a call that they are rolling in a mom who is possibly delivering, the first thing to ask is do we have any information regarding gestation? That's a quick question. Do we think that mom is almost close to term or before term? That will be the first question I will ask. The second thing is any other significant medical history that we know of with mom. What do I mean by that is, did mom already have things like preeclampsia? Did mom had gestational diabetes? Did mom already know about something going on with the pregnancy? So on and so forth. The third question I would ask is what was the reason that mom is now coming through this route into emergency room? Was there a significant event happening? Like did mom had a road traffic accident? Mom fell off? There was a trauma? There was physical abuse? There was something which led to this emergent situation, which I think would be mostly the real life scenario why she ends up, or this was an unexpected preterm delivery. That will be another scenario, because from my experience going to the emergency room when our moms deliver in emergency room, there are possibly, I would say, 2 to 3 common scenarios which we see. One is moms who are involved in trauma or road traffic accidents and are coming for that reason for evaluation and many times delivering. The second is it was unknown or unexpected delivery. So sometimes we have had moms who were not sure that they were pregnant. You would think it is surprising, but we have had moms who are as far as 30 weeks, even as far as 37 weeks, so full term, and not knowing that they are pregnant. And I would tell this is not an uncommon scenario. We all at least see it 1 to 2 times a year when we have this, and mostly these are teenagers, first pregnancies, or other reasons like moms with mental health issues or drug abuse or so on and so forth, who have that story. So I think those are common scenarios. So I think those are the things, like if we can get any idea about term, any antenatal, any sentinel event which led to this, I think that will help you kind of at least prepare and divide if it is something we are going to look for some more like normal term deliveries versus a more complicated at risk preterm delivery.
That is, I mean, that's a great point that if they are in our emergency department, something has gone wrong somewhere. So these are already high risk as it is. That's something to keep track of. How about, gathering a team and equipment? What kind of stuff should we prepare?
Sure. So in terms of that, the first thing is obviously we need a radiant warmer, a place, at least a warmer or a open crib, a place where we can, if nothing else, just make sure that the room temperature is high enough. It's not cold in the place where the mom is going to deliver. Ideally, the room temperature should be somewhere between 74 to 77 degree Fahrenheit to kind of set that up. If we are not getting a radiant warmer at least, and I think the ideal scenario, I think with all EDs should at least have a radiant warmer and some warm blankets, um, and a head cap should be there. Um, those are the few things which you should always need, because as soon as the baby delivers, one thing to keep in mind or focus on is the baby's temperature. If we are not able to maintain baby's adequate temperature, so let me just clarify what is that target temperature. That will be 36.5 to 37.5 degrees centigrade, or in Fahrenheit it is 97.5 to 98.5 degree Fahrenheit. So that's the target temperature for the baby, and it's very important that we do that, because if we don't maintain the temperature many times, that could be the whole reason why the heart rate is not improving. That could be the whole reason that things are not responding as you would like. So that is the first thing you should prepare for. The next thing would be to have a source of oxygen. Uh, and this source of oxygen, when I say, could be things from all this respiratory equipment, like from a flow cannula to a CPAP device. Again, we can talk more about different respiratory device. Uh, so like some form of respiratory support. And the third would be like a suction device, because many times one of the most common complications at birth is meconium aspiration or amniotic fluid aspiration, and just suctioning need. So 10 to 12 French suction catheter with a, hopefully with some kind of connectivity where you can connect it for suctioning. And what is recommended is around 80 to 100 of pressure, millimeter of pressure, where you should set it in, and have your oxygen connected and set in at around 10 liters per minute. Have that warmer ready. I told you about a warm blanket, head cap, because baby's head is one of the biggest surface area. That's where they lose most of the temperature. Um, some lot of towels, because you need to clean the baby. Again, that's the first step. So I'm kind of getting into the first step of resuscitation. So as soon as you get the baby, you need to clean the baby, get that all that fluid out from baby's body, because if it is not taken out, that becomes a medium for the loss of temperature and loss of the body warmth. So you need to clean and dry the babies, and that is also a way of suctioning. Way of stimulating the baby. And when you suction, it could be superficial, and it could be just light suction. Depending on the response and depending on what is going on, you may need to do deep suctioning where you go in, but where it could be just like a bulb syringe, you just suction the nose and mouth. um, and so you need to do all that stuff for the initial step, starting with your resuscitation.
Do you routinely suction all children or only somebody that you think something's in there?
I would
Like a meconium?
the way I would do this is, if a baby comes out crying, and baby is looking quite okay, you don't have to suction. It's not like you have to suction all babies. Having said that, almost I would say half of the babies would need some minimal suctioning. Um, More so if it is again unexpected and unanticipated. It's like a what we say precipitous labor, or any of those labors, like then it would need some mild suctioning, but a bulb syringe will mostly be enough.
Mm-hmm. And then if not something deeper, the meconium,
Deeper,
that's when you would
yeah,
use the smaller
yes,
French
smaller
catheter.
suction. Now that we are talking about meconium, let's talk a little more about meconium, because something has changed regarding meconium. Uh, we get this guideline, I want to say every 5 years, when the guidelines change, and the newest guideline which came in 2017, which is currently continuing. So I think the next update will come around 22 is what I'm anticipating. But the last guideline, basically the biggest change was about the meconium aspiration. It was uh, recommended step that all babies with meconium that you have to connect the aspirator and suction. Now that is not a required step. What do I mean by that? To be honest, even among experts, there is a debate what to be done. But the best way to approach it is again this, that the goal is, yes, aspiration will help only if you think the meconium is causing a physical issue in your ventilation. If the reason why there has been this change is if the baby is really down because of meconium aspiration, again, just to clarify, the meconium is that baby's stool. If it is already baby is already depressed because of that, then it means it has already gone inside the lungs. The damage is done. And you are not suctioning and aspirating out of the lungs. You are suctioning and aspirating from the upper airway. So yes, if when you're trying to see the baby and you're seeing, yes, it is all frothy stuff coming out and you're trying to intubate or you're trying to bag and mask and you see that it is obstructing your physical stuff, then you should suction. If you don't see stuff and although you know it is meconium, then basically the best step is to keep on going on your next steps in an RP as compared to wasting your time to suction.
Right. So just the fact that there's meconium in there, we're not going to say that that's no longer inherently dangerous and we're not going to try to remove it. It's really just to clear the airway so that you can ventilate and oxygenate. It's more important.
Correct.
Got it. Okay, guys, so after we recorded this, I spoke with Dr. Panda and he wanted me to be really clear about something. There's a difference between shallow suctioning, deep suctioning, and endotracheal suctioning. So here are kind of the tools we have. We have the bulb. This is going to do shallow suctioning in the mouth. We have like a French catheter suction. That's what we're going to do deep suctioning with, possibly down to the esophagus, but in the deep oropharynx. We have the meconium aspirator. That's what's going to be hooked up to the ET tube that you can see here. That is to suction the lungs. So to show you how these work, this bulb, this will go in the mouth and just shallow suction the mouth. If you need to suction deeper into the oropharynx, you're going to use this French catheter tip right here. Now, if there's meconium in the lungs, as we talked about, you grab your ET tube, you intubate, then you attach that meconium aspirator to the top of the ET tube. You can use the suction by holding the tip, and of course, don't forget to hook it up to the suction. That's it. What if the baby comes out and they're either gasping or kind of apneic? In that scenario, we're going to have to be a little more aggressive with the airway, with breathing. What should we do then?
Okay, so that's again just I think it will be useful to know a few numbers here. So in general, to be honest, mostly again, like when they're coming to emergency room, I think they are not our general population, but in general, 90 to 95% of the babies will do really fine with just initial maneuvers like cleaning, suctioning, warming. That's enough, and baby should be ready to go to mom. Again, if I'm talking about a term baby in general scenario, I think if by the time they're coming to ER and it is not going as expected, I think those numbers will not be correct. But overall, only 5 out of 100 babies will really need to go towards needing positive pressure ventilation or respiratory support when or having things like being apneic and gasping. And just a number, because we're talking about numbers, 1 to 3 in 1,000 babies will need things like chest compressions and medication, so on and so forth. I'm talking about overall numbers, so the numbers will be skewed for what you guys would see, but I'm talking about overall numbers just to have a background there. Now, as you said, so again, mostly if everything goes well, baby goes to mom. And I know, like, I think one of the questions which you already, which I think I would like to address at this point, is regarding the delayed cord clamping, which is a more advised practice now. So a few things about delayed cord clamping is, yes, delayed cord clamping is recommended if things are going as expected, and when the baby comes out, um, there is no reason to feel that the baby is completely limp or is needing help, then there is no reason to delay that baby's resuscitation to make the delayed cord clamping happen. Delayed cord clamping should only happen if the baby is okay. Okay. For any reason, if you think the baby is down, the delayed cord clamping should be just stopped, and baby should be given to the person who is going to handle the baby, and mom should be taken care by the person who is going to handle mom. The delayed cord clamping, if done, is recommended for around 60 seconds. That's what we would target. 30 to 60 seconds is what is recommended. But again, during delayed cord clamping, the whoever person is holding the baby can still, in the meantime, can wrap the baby, can suction the baby, can keep the baby warm and stimulate the baby by rubbing the back, so on and so forth. Um, Now coming next, okay, let's say this baby now comes to you, and the other thing important to know about as you go through that flow chart, if you guys can, as you can see the flow chart, let me kind of give you the overall schematic over the flow chart. The whole flow chart, if you see into different sections, can be divided into four sections. The first, apart the first one, the first minute, the goal is A, that is airway. The next minute, again, if you're going that way, if with airway, I'll tell you what to do with airway. But if things are mostly are going to be okay in this section in airway, everything is okay, then baby goes to mom. If things are not improving with your A or airway, then you go to the next segment, that is B. That is the next schematic, that is breathing, where you start working on your positive pressure ventilation, so on and so forth, oxygen, the oxygen targets, so on and so forth. When B fails, then comes C. C is the circulation, or chest compression, however you want to say. So the C is when your B fails, your positive pressure, your intubation, all those have been almost achieved, and still you're not responding, then your chest compressions or C comes. D is drugs. That D is when your chest compressions is done, CPR is done, you're still failing. That's when you start using drugs or medications. Another important thing at this point I want to say is, which is very different, and I think this is very important for you guys to understand, is newborn resuscitation and management is fundamentally different from any other resuscitation protocols. Let it be pediatric life support, let it be adult cardiac life support, let it be basic life support, all other life supports, is the whole focus is ventilation. The only thing they want to say, if one thing which you want to remember once you finish an RP, is it is always ventilation, ventilation, ventilation. If you are really going to the C and D section, most likely you are not doing something correct about A and B section. So the chances of need, as I was telling you the numbers before, the reason, again, I was telling you the numbers is, just think about it. If you're really going to that rare scenario of C and D, most likely if you're going that commonly, most common reason to get there is because we are not doing the A and B properly. So, so if anything, C and D should be a rarity, and A and B is what you need to kind of fine tune and focus on. Again, just to give you an idea, the reason is, we are not dealing with someone who has a heart issue. Even with babies who have congenital heart disease, even they will not present with heart issues at birth. That they, even the worst cardiac congenital heart disease, they present with heart issues or cardiac implications later, after the first day of life at the minimum. Presenting at birth with cardiac issues is a rare issue. It is almost always because of lungs. And to understand is because, to be honest, in that 10 minutes or 5 minutes from that being inside the mom to coming out, so many things happen in lungs, where the lung which was almost 90% not doing anything becomes to 100% doing everything in that 5 to 10 minutes. So it's always an issue in that transition, which leads to need for an RP. Okay. uh, just the lungs which are completely collapsed, full of fluids, have to now, with as soon as you clamp the, we are talking about delayed cord clamping, so as soon as you clamp the cord, the placenta, which was doing all the oxygen and CO2 exchange and doing all the perfusion, is completely stopped. All of a sudden, as soon as the clamp goes in, the systemic resistance increases, the baby takes the cry, you stimulate the baby, the lungs open up, and all of a sudden the placenta goes out of the system, and the lung becomes the critical organ doing the oxygen and CO2 exchange within 5 minutes. And as you can see, that huge transition is a reason of needing an RP. So always keep that in mind. It is the lung which is needing help in this transition mode, that we need all this support. So hence, coming to your question, Ryan, about being like gasping or being apneic or having increased work of breathing. Um, so the other thing to also keep in mind with that NRP protocol is, things are ticking in time. Um, if anything, I could very surely say with my experience, it's very important that you have a timer on. I think I should add that to the things which you need to when you're preparing for this. There should be a way to have a timer on. Most of the radiant warmers have a timer, but if not, make sure there's someone who is keeping a time. That NRP thing, the way I approach it is, or I think most of us approach it, is till the time you get to just compressions, everything is ticking in intervals of 30 seconds. And as you can see at that time, that 30 seconds will go very fast. So if someone is not keeping a hang of the time, you will miss the time, and literally a delay of a minute or two will affect this baby short term as well as long term. These babies are just, as you know, with the start of life, and can affect the brain to the effect that it will implicate them for long-term morbidity and long-term neurodevelopmental issues. So it's very important that you stick to the time. So everything there, each section, and everything which you're doing is going in 30-second intervals, is how I see it. What do I mean by that? So baby comes out of mom. Maybe is being, let's say we do a delayed cord clamping of 30 seconds to 60 seconds, but during even that 60 seconds, someone is checking on the baby. For example, let's say baby is not doing well. You ask, okay, let hand me the baby, and the baby at least comes to you by 1 minute or before 1 minute. And within the first 30 seconds that you have the baby, you quickly examine the baby, and try to get a heart rate, and try to, there is I think I missed the part of the TLC, or the first three things which you look for at birth. That is, if the baby is and how is the tone. L is for, so I try to use TLC. Let me tell you about that too. So TLC, or the tender loving care, I use that as my mnemonic for what to check to for the first three things which the NRP gives. So the T stands for term. The L, what I'm trying to use is for limp. So if baby is limp, so like looking for the tone, and C is crying. If the baby is crying or breathing, if baby has a strong cry, then the baby is breathing. Sometimes again with some intermittent cry, also the breathing might be compromised. So whenever, even with the shorter, smaller doubt if baby is really doing a good job about breathing or not, always the to go place for assessment is the heart rate. So as soon as you get the baby, you need to kind of assess all those things, including the heart rate. So how do you assess the heart rate within this 30 seconds? The reason to do that, the way to do that is, I think you need to have a system. Either many of us use a 10-second system, or some of us use a 6-second system. What do I mean by that? You basically, someone is looking at the clock and trying to check the heart rate. Now, how to check the heart rate? Ideally, just check the heart rate with a stethoscope, auscultating on the heart. Never try to check the radial pulse. Never try to check the femoral pulse. Never try to check the brachial pulse. No, those all are no's. The only way you can try to do, apart from auscultation via stethoscope, is to try to feel the umbilical pulse. Having said that, if you're not able to feel the umbilical cord pulse, and I will tell you that almost half of the times it is very feeble, or it is unclear. So don't waste time. And have your stethoscope again. I think that's probably another thing to have. And I'm hoping even with the big stethoscope, with the adult stethoscope, you'll be able to hear. You should be able to hear the heart rate. And when you're trying to hear the heart rate, again, not to hear it for 1 minute, only hear it for 6 seconds. And the ideal way to do it is, again, hopefully there is a team there. Someone is putting the diaphragm of the stethoscope on the baby's chest on the left side, ideally, and then someone is using their finger to see at the clock and just sticking like this. So let's say, for example, just by when we do it more times, by the way the fingers move, we know that if it is good enough or not. So for example, in 6 seconds, it should be at least, let me say my number correct, is 10. So there should be at least 10 beats in the 6 second. So if you do it like 10 times in the 6 seconds, then your heart rate is 10. 6 times 10 is 60 seconds or 1 minute. So your heart rate should be more than 100. Once you are more than 100, you're good. You're good, or you can be, or what you can say is you can breathe and you can just go step by step. If your heart rate is less than 100, you just need to go to the next step quickly and you don't have time to waste. That's basically the main point. So another, I think something in bold here, your heart rate is the most important vital which you're going to use to go to your next steps in NRP to escalate care or de-escalate care, or to see response to your care. Okay, so when you say baby is having apneic or is gasping, and you check the heart rate, if the heart rate is less than 100, no wasting time, directly doing positive pressure ventilation, PPV. Okay, let's say your heart rate is more than 100 and it's more of a saturation issue, then you can use some free flow oxygen, like just have a cannula by the nose, just again do suctioning, so on and so forth. You can do the initial steps. But if the heart rate is less than 100, then just positive pressure ventilation. Um, Let me just tell, I think it will be the following question: how we do the positive pressure ventilation will be through a right mask. Um, then comes the about the, again, I think it is with the equipment and with the baby, is we do need to have the right size of the mask and the right size of the endotracheal tubes and the laryngoscopes, um, so that we can do the management correctly. Sticking to the positive pressure ventilation, what you want is that the flow is at least at 10 liters with the positive pressure. You can use a self-inflatable bag, or that's the anesthesia bag, or the flow inflating bags. We would recommend using flow inflating bags as compared to self-inflatable bags. Um, and by using that, you will be able to, there are other different CPAP device which are available in the market. Sometimes they are called as T-piece resuscitators. They are actually much more easier to use and more user friendly. There actually you can directly, it is like a T-piece with the vent, and the mask comes on the baby, and you can exactly put the CPAP pressure of 5. That's what we will go for, and start having a good seal. When you're again having a seal on the baby, make sure that the mask is not too big that it is putting pressure on the eyes, and then if the eyes are getting covered, then that's too big. If the nose and mouth are not getting covered, then it's too small. They're mostly like 3 sizes. I think for your purposes, mostly if you're dealing with a term baby, there's only 2 sizes, 1 and 2, which you will be dealing with. Which again, depending on that, just try to do that and start using positive pressure ventilation. Once you do that positive pressure ventilation with the CPAP, then in the meantime, if for any reason you are needing positive pressure ventilation or you are in that route, then the next thing is make sure that we start putting the pulse ox. That's another recommendation, that there should be a pulse ox put in, ideally in the right hand. No other place. Not, you don't use the legs, don't use the left leg, because left hand, because it will give you numbers which will be not be good enough, and you might again overdo things. So always the right hand. And always it's good to have a blender system, but if not blender, at least there is a way to give 100% oxygen, because then you will be dealing with the CPAP and the FiO2 percentage to kind of get your pulse ox numbers, as again probably showing in the NRP what are your target sats depending on the time of life.
Mm-hmm. That was a lot of stuff. That was great. For the pulse thing, I like this. What about putting them on just like the monitor? Does that help at all? Or?
Like the EKG monitor?
Yeah.
Yes. So yes, it does help. The only thing I would say is, if what happens is many times in the initial steps, when you're trying to still clean the baby, so on and so forth, we will be still slimy, things will not be sticking, so on and so forth. Having said that, if you are going to the next steps in an RP where you think the baby is not responding as they should, and you are getting towards chest compression or intubation, then you should put the EKG monitor, so that we don't waste time in auscultating, so on and so forth. So that is the recommendation. Yes, so earlier the better if you can, but just to keep in mind that initially, till the time baby's overall perfusion is not great, or baby's like slimy and wet, those all things might not work. Same thing with pulse ox too. I would like say that the pulse ox is also not as straightforward as it sounds. Many times the pulse ox doesn't work. Sometimes the number might not be showing. So you have to really look at that graph and see that if it is really giving a good graph and it is sensing it correctly before you go by your numbers. Many times, initially the baby's overall perfusion is down and it may not pick up. So again, that time, again, it's your auscultation which will give you guideline uh, regarding how to go to the next steps.
And then in your experience, is it usually, I mean, if you're getting down, past A and you're into the B area, like you were saying, is it usually a ventilation issue, or like they just don't have the mechanics to breathe yet? Or is it like an oxygenation issue in your experience?
That's a good question. When you say that, mostly the ventilation and oxygen, they go hand in hand in
Mm-hmm.
this case, because it is more of the fluid interface which is obstructing it. And that's the reason why we're talking about positive pressure ventilation. By doing positive pressure ventilation, it causes that distending pressure to get that fluid out of the lungs. Um, so they're kind of, it's a mixed ventilation oxygen issue, but because at that time you cannot target your CO2s, so the way to target it is through oxygen numbers. And hence that's the reason why we are going with the pulse ox and the oxygen values for those time periods, and then targeting your FiO2 starting from 21% or 30% to keep on going to 40, 50, 60, 70 to 100% if you're not achieving your target oxygen saturations.
Right. And I mean, just the reason I kind of think that is, in an adult that is a little bit hypoxic or having respiratory issues, position their airway, suction them out, make sure the airway's okay. We can try like blow by or just like a cannula, some oxygen over the top, where it seems like this kind of more supports the pressure is more important, the positive
Correct.
pressure.
And then the positioning is also important. I think I know that was one of your questions too. Like what kind of position? So let's talk a little bit more about, because I think that is what you guys are going to spend more time. As I was saying, it is more of airway and breathing. So we talked about a few things about having a CPAP proper device and a proper mask for the baby. But then the other important thing in the NRP, which I think to remember, is the MR SOPA. That is basically your tool to work with when you're dealing with your A and B together kind of. So MR SOPA is kind of the mnemonic, which stands for, M stands for the mask, the right size of the mask and having the mask correctly. R stands for repositioning. This repositioning is positioning the baby correctly. And the ideal position for the baby is the sniffing position. What does that mean? As in medicine, as with everything, like we are always, I think it mostly the story is that it comes from food, as we have a lot of things with food in medicine. So sniffing is, just try to think about it this way, like you get a good food which is hot coming out of, you're in a restaurant, it comes out and you're trying to sniff. You never sniff like this, you never sniff, you sniff and you semi extend. So that's the position you want. So like, so there's semi-extension. So it's semi-extended because the airway in babies is very anterior. So by doing that semi-extension, not super extended, but when you do super extended, again, you lose that straightness. So you need it semi-extended so that it becomes straight to your oropharynx. The laryngopharynx becomes straight to your oropharynx, and your airway or your mask works. Okay. I think it's easier to show on a mannequin or on a person, but so that's how it is. So that's your big part, like that repositioning. Then S in MR SOPA is suctioning. So again, if there is a fluid in the mouth, fluid in the nose, with suctioning, always remember, as with the alphabet, M comes before nose. So suction your mouth before your nose. Okay. That is, as O is open your mouth. Sometimes you may even use your finger because you're trying to use both the nose and mouth as an interface so that you can give that air. Sometimes using a small mouthpiece might help, or sometimes even using your small pinky to open the mouth to kind of, or when you angle it, helps to kind of transmit that pressure. And then P is the pressure, MR SOPA. P is the pressure changes. So you start with your CPAP of 5 or 6, and then you can start giving PIP on top of that, like your 15 over 5, 18 over 5, 20 over 5, 25 over 5. And A is when all those things have failed, then you go to A or alternate airway, trying to intubate.
Mhm.
So as I was telling before, with this whole airway breathing, till the time your heart rate is above 100, you have time to keep on working on each part of it, fine tuning it. When you're doing it, then recheck in 30 seconds. I would do things again in 30-second intervals. Like you do something, redo it in 30 seconds, come back to the baby, check baby's chest movement, airway. You can auscultate the baby's lung. How is the air entry? See the heart rate. Okay, it's going well, then you can just continue. If not going well, maybe you can tweak it again. But anytime the heart rate goes less than 100, then you directly just, it's again, it depends, but if you really know that there is something in MR SOPA which you can fix before going to the airway or putting the intubation, then you can do that, but otherwise not waste too much time and directly go to the intubation. Okay.
When you're positioning the airway for the baby, say you're doing some sort of bagging or something, is it similar to adults, kind of like a jaw thrust, or to open them up?
So a jaw thrust will help, but again, it's very mostly when you're just using your fingers in that C loop, you're making that C and stuff, and with the mask, when you're holding your mask here, the C and E, and then you're just trying to do that. Again, it's like a more lighter jaw thrust as compared to even what we use in PALs. So a little bit of jaw thrust, and with that positioning, it helps.
And then what rate are you bagging at, and
Right.
how much tidal volume?
So 30 to 40 breaths. I think the target is 40 breaths per minute. Per minute is what we are trying. So almost each breath every 1 to 2 seconds is what you're trying to do. Uh, Coming to the tidal volume, I know the concept of tidal volume for us doesn't come because here we are trying to see the pressure.
Mm-hmm.
So I think that is, and I think I may be ignorant about how do you do the tidal volume for adults and for older folks. But for our babies, what happens is because we have that manometer there with all our devices, which gives us the pressure. And that's the reason why the importance of the TP's resuscitator or having that manometer. So if you look into any of the NRP books, like they will always show you the manometer. So that tidal volume, how much you're giving, depends basically till the time you see that pressure of 5. So that's how we decide about the tidal volume as compared to the volume as such. Does it make
Right.
sense?
Yeah. On the dual ones, we just have this little, it's like a similar, like a peep valve. You just twist it to whatever set.
Correct. So you
5
can
or
do the
whatever.
same thing. So, but yeah, so we go by that. So like whatever you need to get that 5 is what you're going to use. But as a prerequisite to it is have your flow set up to 10 liters per minute. Sometimes you may have to go to 15 liters per minute, and having a good seal and a right mask. All those are important so that you can deliver that pressure.
Mm-hmm. That's good. And so we're working here, A, B, checking the heart rate, airway, breathing. Those are the things we're working on. If the heart rate never really dips below 100, but say their tone's not great, we can still work longer, 90 seconds, 2 minutes, 3 minutes. We can do it as long as the heart rate doesn't drop, correct?
Right. Till the time heart rate is more than 100, you guys means you're good. Okay. And more so, again, if you're doing it correctly, the heart rate should keep on improving. And mostly for a newborn, it should be around like 140s to 160s or at least 120s. So you will see that. And the best way, again, that's another commonly asked question, is the best way to even see response to your intervention is your heart rate. So if really you have solved the problem or you are already kind of moved the baby around, the heart will keep on improving. If for some reason it is just stuck there, or the worst thing is something that either something which worked for some time or something which you need to do more at this point.
Mm-hmm. And heart rate, and it's more important than the SpO2, really, yeah? Or what do you think?
Yes, I would say yes. Heart rate is more important than SpO2. SpO2, yes, is going to help you in fine tune, but your major steps will be heart rate dependent.
Mm-hmm. All right, this has been amazing. Let me make sure I asked everything we wanted to up to now. Perfect. So, God forbid, we have a case, comes in, we follow Mr. Sopa, we think we have a good airway, we think we're ventilating appropriately, but the heart rate does dip. Say it goes below 100, but it's above 60 still, kind of in that sweet spot, 60 to 100. What should we do then?
Okay, so when you are below 100 but above 60, so still, so you don't have to start going to C or just compressions till the time it is not below 60. So you still have room, but there is a time ticking. So the reason again is when the heart rate is less than 100, as I was saying, that basically directly correlates to poor brain perfusion. That's the reason how that number comes. It's not just because of that, because we know through animal studies and other studies that as soon as the heart rate goes to less than 100, the cardiac output goes below a point that the brain perfusion is maintained. So basically, then you have to do something so that the heart rate comes quickly up. Okay. So yes, as I was mentioning before, you can kind of try to still refocus and see if there's anything with the MR SOPA, but you are not going to waste more than 30 seconds in trying to get ready to intubate.
Yeah.
Let me say it here. I think it is more important that there is a possibility to use a laryngeal mask if required. The laryngeal mask size, the new NRP does talk about laryngeal mask. Again, the laryngeal mask, the smallest you can use they should be at least 2.5 kilos, or at least should be around term. The laryngeal masks are not supposed to be used for preterm babies. The LMA size of 1 can be used. I would say in my experience, I have mostly used LMAs when there is congenital cleft lip, palate, and oral deformity issue as compared to in normal resuscitation. But I know I have had incidences where we have used LMA for a short MRI procedure and stuff. So it does work well for full-term babies. Just make sure that again the suctioning is done well, all those things have done well, and then you're using the LMA. And if you get, I'm sure if you guys have used, it's very simple. It just scoots in, and then you should be able to use LMA like a endotracheal tube. But keeping in mind that many times if things are in your airway, or either it is meconium or secretions or it is lungs, uh, your LMA might not be able to transmit all that pressure properly, and hence you should be thinking about intubating.
Mm-hmm. Okay. So let's talk about intubation and like what size tube, what size laryngoscope, do you do VL, DL? Talk
Right.
about it. Mm-hmm.
So few things in a way which is simple for us is it's always a straight blade. Okay, it always has to be a straight blade, and for your purpose it should be, in total for our purposes there are three sizes of blades we can use. It's 00, 0, and 1. Okay, for a full term baby, the way I think about it is if baby is less than 3 kilos or less than 2.5 kilos, I would use a 0, but above 2.5 kilos you can use 1. Again, that's kind of the vague guideline. Actually, that brings me to another point is whenever you are getting a baby, another thing to have in your mind, depending on the gestational age or what you see the baby, is to have a weight cutoff. The weight will come handy to you at this point. I think till A and B you don't need the weight, but as soon as you come to intubating, so I think the later part of the intubating and the chest compressions and the medications, you need some kind of weight cutoff, and you might not have enough time to check the weight, and you should not waste time in getting the weight. So depending, hopefully we are good with our approximations, so you should use something like 2.5 kilos or 3 kilo. A normal full term should be around 3 kilos. That's a to go weight. um, so um, so coming back to the intubation part, so three blade sizes, always straight blade, the Miller blades, and we always use direct laryngoscopy. I know we have used video and laryngoscopy and stuff for training, but I have not. We don't use it in practice. We always use direct laryngoscopy and the straight blade, and that's a blade size. Then coming to the tube size, there are only three sizes: 2.5, 3, and 3.5. Most importantly, uncuffed ET tubes. So never cuffed ET tubes. It can cause laryngomalacia, laryngeal damage in babies. So always used uncuffed ET tubes. And they're only, again, for if it's a full-term baby, 3 and 3.5. For a preterm baby is 2.5. So again, the weight cutoffs for those are, if a baby is more than 2 kilos, let me think about it, more than 2 kilos, then use 3.5. So for most of your babies, you should be needing a 3.5 ET tube, which you should have. Obviously have 2 to 3 of them ready. Always have the lower size ready, because if you have issues, sometimes that's going downsizing the ET tube might help sometimes. So always have 3 and 3.5 ready for, if you have to prepare your thing, have 3 and 3.5 ready, and your Miller blades. And then basically when you're trying to intubate, coming to the whole process, the main steps are, again, you want that sniffing position. That's very important. The way I generally, few things which I would say are again important for neonatal intubation is preparing, obviously the positioning the baby as per your height, um, having all suctioning, so on and so forth, having the pulse ox ready, hopefully the EKG monitors put in, having your mask, bag and mask well ventilated, and hopefully again, this at this point I think you're crashing, so you're trying to do as the best as you can, but hopefully our heart rate is still above 60 at this point. You suction, you use your hand to kind of try to that position. What if I'm right-handed? So let me see if I'm going to say it right. I will use my left hand, use my index finger to open up the mouth. That helps me open up the mouth, because otherwise, and the babies don't have teeth, so they don't bite, so it's safe. Then you use your laryngoscope, go in, and then when you go in, so after you go in, again, the other thing is with them, no more twisting after you go in. When you go in, for example, let's see if I can, I don't think I have something like that, but let's say this is my laryngoscope, so like this is our scope and this is my handle. So when I go in, I scoop out the tongue. I try to find my epiglottis. as soon as I see my epiglottis here, which is flickering, I try to hold my epiglottis. As, when my epiglottis is in the end of my blade, then I basically just move it
Mm-hmm.
90-degree angle and just move it outwards. No angling this point, outwards. When you do that, that's as soon as you do that, you will see the many times actually it's pinkish vocal cords moving. Okay.
Mm-hmm.
The main goal with intubation with newborns is trying to find those vocal cords. Many times, if you're not seeing the vocal cords, and if you're going to attempt, you are going to go to the esophagus. Um, so if you're going to do it initially, make sure that take your time to see the vocal cords, and then put the tube in. So obviously, you you see the vocal cords, ask someone to hand you the tube, then you put the tube in. Okay. And once you go the tube in, the other way to the few ways how you can see how deep you want to go. But commonly, what we would use for how deep we want to go in the endotracheal tube is basically a simple formula of using 6 plus weight in kilos. So let's say you're saying a baby's weight is 3, so 6 plus 3 is 9, so 9 centimeters is how deep you should go.
Mm-hmm.
I know there are other techniques of doing it, like the Traeger's mouth and stuff, but to be honest, I don't use it. I always go with my weight estimation. Then you do that, then listen to the lungs, and hopefully a
Mm-hmm.
chest X-ray, and then that's how you confirm. And as soon again as you have the tube, again make sure that someone is securing it, and you start giving your breaths through your ET tube that time.
Mm-hmm. And then do you use a stylet?
I would say for your group, you should use a stylet.
Mm-hmm.
Um, we sometimes use, we sometimes don't. The benefit of stylet is yes, you can curve it, but again, prepare it properly before you go in, and make sure that the stylet is not coming out of the end of the AT tube,
Mm-hmm.
because there has been instances of injuries because of that. Yes, I would say if you're not, this is not something which you commonly do, I would recommend using stylet. That does make it easier to do.
And this may seem like a silly question, but we're not paralyzing. This is a crash thing, right? So we're just
Correct.
straight tubing them. Okay.
Correct. Most yeah, if most of this most of the NRP related endotracheal intubations, we never use any medications.
Right. Right. And then, in your experience, where are the problems with intubating? Or where do you, if you have a problem, what is the problem? The most common problem going to be?
The common problem could be few. One thing is we are not correctly estimating the size. Okay, so for example, maybe the baby is small and you're trying to put a bigger tube, or baby is big and you're putting a smaller tube. So when you do that, then you're not getting a good seal because there's no cuff there, so you will lose a lot of your volume. So that could be one thing. The other thing is positioning. Oh yeah, I think I missed one part, that the cricoid pressure. So always ask for the cricoid pressure. I think that's again another very something which I find very useful. I almost always use it with all my intubations, that you're asking someone to put that cricoid pressure. The problem is basically it's so anterior. There are two things, at this point with this baby who is really that down, that baby is not going to fight. So you should not be having issues with fighting. Sometimes the bigger baby who is otherwise fighting, the fighting could be an issue because you're not using any kind of paralysis, but mostly that's not the issue. The problem is that it's so anterior, is that it's really hard to get to that anterior. So as you mentioned, the stylet, the positioning, the record pressure, all those things should help. So that is one. Second, if still you are having issues at that point, it could be an upper airway congenital issue. The ones which I have really got stuck with is there has been instances of laryngotracheal clefts where you have basically the larynx and the esophagus, they're all in the same loop, and so it's, even if you're in the right spot, it's not ventilating. Things like laryngeal web, or not having a completely open larynx, or vocal cord palsy, or yeah, like rare stuff that can cause them to happen. But like anytime if you see some kind of dysmorphism, or you see things with cleft lip, cleft palate, those are the ones which are going to be difficult intubations even for us. And I think if you're already seeing that, is to anticipate and have someone on standby, or have your anesthesiologist, or have someone to be on your backup.
Yeah, or maybe even like an LMA, or just
Right,
don't go so
or be
deep.
using an
Yeah,
LMA till that time. Yeah.
yeah. It was really good airway stuff. So let's just move on down the algorithm here. So say, now the heart rate is below 60. We've gone through all these things, and now we have to start compressions. How should that look?
Yeah. So as soon as you, again, if you're going to start compressions, the one thing is make sure that you are intubated by that time. The recommendation is by this time you are intubated. So you, again, because the ventilation is the focus, the goal is by this time you have a secure physical airway so that you have done everything what you can in terms of ventilation if you're going to chest compressions. Okay. So have the airway secure before you're going to chest compressions. Now, when you have to start chest compressions, by this time, what happens? One thing to remember in terms of your positioning is the head of the baby is always coming on the edge of the on the radiant warmer. So by till this time, the breathing airway person was kind of on the head. So now this person should move to the side, and the chest compression person should come to the head, because now there is an airway and they can just bag and mask through that. And the chest compressions are better given when you are on top of the head. And the ideal way to do it is through the two thumb technique. Okay, not the two finger technique anymore. It's almost out of practice now. So it's two thumb technique. So you basically try to wrap up the whole chest and try your basically landmark is the line which is joining the nipples. You just try to put your thumbs just below that line, that imaginary line. So it's kind of the lower part of the sternum, and then give compressions deep enough that you go 1/3 of the chest of the AP diameter. That's how much you're trying to go. So it's quite significantly deep. And the way to do it is once you're going to the chest compression mode, the goal is to have total of 120 events in a minute. It basically goes in 2-second intervals, and it is basically 1 and 2 and 3 and breathe. Okay, 1 and 2 and 3 and breathe. So this is happening in 2 seconds each cycle. So four events in a cycle, 3 of chest compressions and 1 of breathing. So 4 times 30, that is 2 seconds. So that's how we get 120. So when you are doing, so as you can see, this is basically happening even in less than half a second. So sorry, the chest compressions is happening in so it's quick, effective, still deep enough, and you have to release so that the chest that completely relaxes, and there is that reconcile. And then when they're doing the breathing, that's when you stop. You don't do the chest compression. So 1 and 2 and 3 and breathe. Okay, so someone else is doing the breathing for you. So that's how you want to finish 120. I was telling to you, till this time, everything was going in 30-second periods. But when you go to chest compression, that's when you want to do the whole 60-second before stopping to try to listen. And hopefully by this time, you have your EKG monitor and your pulse ox and so on and so forth to look at your heart rate. That will be useful, and you will not waste time in auscultating, but not to stop your chest compression in less than 60 seconds to try to auscultate. So do your 60-second cycle and then check. If so basically after your 60-second cycle, if still your heart rate is less than 60, that's when you go to the D or drugs and you start getting ready for your epinephrine.
Okay. Right. How do you get access? What access do you recommend?
So good. So a few ways. Ideally, we recommend the UVC. But again, it's something I don't know how much you guys are comfortable doing UVC, but if it is not something you guys have done, IV is okay. So another thing to keep in mind, again, a lot of this is about anticipation. So NRP is all about anticipation. So although I talk about A, B, C, D, if you are going from A to B, you're already thinking about C. If you're going from B to C, you're already getting prepared for D, because within a minute or so, if you're not planning ahead, you are going to lose a lot of time. Even with that planning, you lose time. So as soon as you're going towards intubation, you should be asking someone to try to get an IV or getting an IO. It's okay. For full-term babies, you can put an IO, the most common site being the tibial, anterior tibial site. So anterior tibial, let's say this is my tibia. So like the anterior tibia, just in the tibial tuberosity, just get it in. So the IV or IO site is recommended as compared to the endotracheal site. So you can give through the endotracheal tube the epinephrine. The epinephrine is always 1:10,000. And the ideal way to remember the dosing is in mLs per kilo, not in milligrams per kilo. Although many times you will see NRP talks about milligrams per kilo, and that's very confusing actually. It should be 1:10,000, and what you want is 0.1 to 0.3 mLs per kilo. Again, another place where you will need your anticipated weight to kind of call in the epinephrine and get the epinephrine ready. You can give your first dose through endotracheal tube if you think the baby is really that low and will take you some time to get access. For the endotracheal tube, that the dose is almost tenfold. So the dose is zero point 0.5 to 1 ml per kilo through endotracheal tube. Same concentration, but through the endotracheal tube. But the goal is, even if you gave your first dose, remember that the many times the endotracheal one will be not effective or will be very transient effective, because the amount which goes by the time it gets absorbed from the lung to the heart where it does its work is kind of lower as compared to if you do it through IV, it should work better. And all, if you're giving through IV or IO, make sure you chase it with another like a 1 to 2 cc's of normal saline. In terms of drugs, the other good part is in NRP, there's not a lot of drugs. It's mostly epinephrine. The second thing which you might need would be some kind of fluid resuscitation. And I think that's very important from your standpoint, because if this is a mom who had trauma or who had a lot of bleeding while she was delivering and there was a placental abruption, so on and so forth, that bleeding some part of it could be coming from the baby. So this is probably one of the babies which you should try and think about giving some kind of volume resuscitation as soon as you get an IV. So if the volume is really low, so the ideal the solution to be used is normal saline. And another important thing to remember is that the dosing which we use is lower than pediatric or adult. It's 10 ml per kilo, not 20. So 10 ml per kilo of normal saline, or if you know for some reason there is a significant blood loss, you can go ahead and give O negative blood too. But normal saline would be otherwise handy, and that's something which you will use for, again, where you know that there is a reason for that fluid loss or some reason for hypovolemia going on. Common scenarios being trauma, common scenarios being abruption, other one being the umbilical cord coming off, maybe just bled from that, things like that.
I mean, for the adults, we always try to go through like the H's and T's, is there something similar for kiddos or for
No,
these kiddos?
no. For NRP, actually it's much more straightforward that way. So in terms of the drugs, it's very limited. To be honest, it is just epinephrine and fluid. Everything beyond that, to be honest, if you're getting there, is we're already losing ground. Yes, there are things like sodium bicarbonate, which we have used. Sometimes we have used things like adenosine, so on and so forth. But I would kind of stay away from all that. Again, that's something which I have used once in a year or once in 2 years. Yeah. So that's that rare.
How long would you consider, you're doing chest compressions for so long, how long would you consider to stop the chest compressions and just call?
Correct. So then comes I think that's a very good point, and that comes to the ethics of newborn resuscitation. And this is actually, to be honest, it's not uncommon from your perspective. I would say in the last 3 years, I have been called to ED. Almost half of the times the baby didn't make it, because we are mostly, it's mostly two ways in ED. It's either everything is okay and the baby doesn't even come to us, or the other way, when the baby was down for so long and by the time baby comes, it's almost a lost game. So that's an important and a good point. So actually, to be honest, another important thing is when the baby comes out, if you don't hear a heart rate at all, something very important for you to document. If for some reason, another thing in the same lines is, even when the mom comes, are you able to even get a fetal heart rate? If you don't see a fetal heart rate, that could be something which probably the baby was still born to begin with. Maybe it was a fetal demise as compared to a neonatal demise. And those are very important points to keep in mind going further. To answer your question, Armin, the answer is 10 minutes. So when there is no heart rate for 10 minutes is when you stop resuscitation. Having said that, in real life scenario, this mostly turns to almost 20 minutes, because by the time you do everything, you get your lines, you give your epi, and you still are not doing, basically you want to do everything, and still 10 minutes after that, there's no response or there's no heart rate, is when we would stop. So yeah, by definition, 10 minutes of not responding or no heart rate is the time to stop. In the same lines is, if you have a baby who never had a heart rate to begin with, maybe that's another one. You don't even have to do 20 minutes. Maybe, you try to do stuff, but maybe even sooner, 5 to 10 minutes, you can call it call it off. Means I would still give it a try. Um, but the other one would be like extreme prematurity. Sometimes you can have moms who basically delivered at 20 weeks or 21 weeks. Like our cutoff for trying to resuscitate is 23 or 24, with all possibly everything else done with mom, so that we can think for a favorable outcome. But again, if extreme prematurity would be another reason to also not push the limits. So yeah, that will be the approach.
That was really good. Well, that's awesome. I mean, we made it through the whole algorithm. Hopefully, in real life, we don't have to make it through that algorithm. We can stop somewhere up high. But do you have any kind of final suggestions or pitfalls or any final comments?
No, I would say the final suggestion would be again ventilation, ventilation, ventilation. If you are reaching the C and D, please someone reassess the ventilation. Did we do everything correctly? Did we do the whole MR SOPA? Did we do the right 100% oxygen? Did we use the right mask? Did we use the right tube? Another important one, are we missing anything? In terms of missing other stuff, the big one is pneumothorax. Okay, so that probably is one thing which you can, one thing why you would need an X-ray. So one reason why you can call for an X-ray to begin with, because sometimes it will be hard through any other way to find it. But one thing you can see is the seesaw pattern, what we say. So basically, if there's a big pneumothorax, you'll see a very discrepant right versus left movement of the chest. When you see that, or when you're oscillating, you see a very discrepant difference in what you're hearing. The pneumothorax will not respond with whatever you do till the time you aspirate or you put a chest tube. Okay, I think from an emergency point is basically try to do a needle aspiration is what I would recommend. And again, we try to go through in the second or fourth intercostal space in the mid axillary line, or you can go the mid clavicular line and try to just aspirate as much as you can. And again, so you're basically talking about the at that point I would not be worried about, okay, I'm going to injure and stuff, because that's, you're trying to do the best. And yeah, in real life too, like if it's a pneumothorax and anything else will not work till the time you take care of the pneumothorax. And yeah, I think the other thing is, the other thing, caveat to all this is the weight and the dosing. That's another one. Even with us doing it so many times, there are so many times that the dosing and weight calculation can go completely off. And I can see that more happening with you guys, being more used to bigger numbers. For example, a dose of epinephrine of 0.1 mLs per kilo for a 3 kilo baby is 0.3 mLs. If you end up giving that either 3 mLs or you end up giving 0.03, it will not be effective. And I would say in my real life too, that has happened. So that dosing and keeping in mind that how the weight frame is so different is very important to keep in mind.
Mm-hmm. Yeah, that's excellent. Cool. Well, Dr. Panda, thank you so much for doing this. We're going to share this with all the ER residents, hopefully some of the PEDS residents and stuff as well. Thank you very, very much.
No problem. Thank you.
Thank you very much.
Take care, Armin.
Good one.
Thank you. Thank you, Ryan. Thank you, Armin.
So lots of stuff that Dr. Panda was telling us, and some of the things, Ryan, that I got out of it is just the first thing that you want to do is the 3 questions whenever the patient's getting wheeled in. You want to ask the gestational age, past medical history, event leading to this delivery. Now you want to set up the room. How are you going to set it up? With the temperature at 74 to 77 degrees Fahrenheit. You want to maintain that target temperature for the patient at 36.5 to 37.5. You also want to have that warm blanket, that head cap, that timer, that stethoscope. And speaking of respiratory support, you want to have that low flow nasal cannula at around 10 liters per minute, have a CPAP device around that you're going to place at 5, maybe 6, 10 to 12 French suction catheter, and also place suction at 80 to 100. And you want the ET tube and laryngoscope. The laryngoscope, you want the Miller blade, and for a full-term baby, which would the one that we're going to be exposed to more than likely, which is more than 3 kilos, it's going to be a 1 size 1. And for the ET tube, you always want to do uncuffed, and it's going to be a size of 3.5. But he mentioned to always have one less size, or a 3, if just in case you're not able to intubate during that time. So also he mentioned not all babies need suction, and it also, because of the ABCDs, you do the airway and the breathing, which are the most important ones. And if you're going to the circulation and the drugs, more than likely you're not dealing with the A's and the B's adequately, so reassess with that. He also mentioned that the heart rate is the most important vital sign, not the pulse ox, nothing else except the heart rate. And by auscultation, or you could do the umbilical cord pulse, right? And while you're auscultating, you let the whole team know by your finger taps, okay? The best response of your intervention is going to be measured again by the heart rate. About positioning also, and about the Mr. SOPA mnemonic that we use. You want to do the mask for the right size, repositioning, the sniffing positioning. You want to be semi-extended, not hyper-extended. You want to have a good suction for the S, suctioning, and you do the mouth before the nose. Also, you want to open the mouth, and the pressure for P, you want to have, again, the CPAP pressure of 5 to 6. And if you're going to do PIP, you could go start off 15/5, 20/5, maybe 25/5. And last of the mnemonic, it's the artificial airway. And always when you're going to bag, he mentions to do 40 breaths per minute. Now, when you're talking about the heart rate, it's fluctuating between 60 and 100. You're not yet at the compression, but you're not yet at the time to stop doing PPV. You want to do about 30 seconds, maybe a minute, and reassess. When you do that, you could do an LMA. However, he did mention that the LMA is usually going to work whenever you see difficult intubation. When you see a dysmorphic patient, then that's when you think about an LMA. And after you go on, you want to intubate that alternate airway, you're going to go into the airway, and he mentions not to do the twist of the wrist, always lift at 90 degrees, and cricoid pressure here is really accepted, and he uses it a lot, and he encourages us to use it. Now, when you intubate, how deep do you want to go? You use that formula, 6 plus the weight in kilos. Usually he's going to be 3 kilos, 3.5, so you just go in 9.5 centimeters. And whenever you asked Ryan, which is a very good question, what's the most common problem intubating that he runs into? It's the size of E2 tube, and that's why he mentioned always have the correct size, 3.5, and then the 3, just in case you're not able to intubate. And whenever you do have that heart rate of less than 60, you want to make sure that you have a good intubation, because if you have a good intubation, more than likely your problems are going to resolve, being that neonates most common cause of this cardiorespiratory arrest is the respiratory system. So then you intubate, you start the compressions, you're going to use the 2-thumb technique. You do 1/3 of the chest AP diameter, and you're going to do a total of 120 events per minute. That's 3 compressions per 1 breath, and you multiply, and that gives you the 120. After this, whenever you're doing the compressions, you do not do reassess at 30 seconds. This is when you switch, and you are going to reassess at 60 seconds. And that is it.